Hello, everyone. I'm Dr. Shivangi Jain. Welcome to Geriadent 24. Today, I will be speaking about implant-supported overdentures, a reliable treatment modality in geriatric patients, an overview with case. I want to just share that I truly enjoy doing removals. Now, removals is something which, I've done plenty in my career in the last 20 years. Regular conventional dentures, and then you have magnets and you have overdentures with the different types of attachments and cast partials. And after doing a lot of things, I may choose to, obviously every patient has different demands and different needs, which we tackle and handle. But what does a patient really need or want? So we may want to give them anything, but what they really need are just two things. One is function, and the second one is aesthetics. So how we give it to them, because when we treat geriatric patients, they are not always medically really fit. So many a times they are medically compromised, or they have financial issues, or travel issues. And so at a certain age, we at the Board of Geriatric Dentistry recognize that one treatment doesn't fit all, and we need to think out of the box, come up with simpler treatments. And if we have more complex treatments, then we need to, shorten the time of appointments and work accordingly, and having an open mind about it. Because I may feel that, something is more ideal, but it may not be the best fit for that particular patient. Now, I have done a lot of dentures, and I truly enjoy doing conventional dentures as well. But there are problems with them. You may be able to satisfy, a lot of patients, but there are a lot of, there are a lot of problems associated. For example, there would be some patients who would say that, okay, the dentures are loose, or they really can't chew that well because of, pain or movement. There's discomfort, there's more bone loss. And all of these kind of come together, and the biggest problem is compromised quality of life. And that is something which we don't want. So ideally, the best option would always be to go for fixed, because then the patient is not worried about, keeping it properly, and it wouldn't really get lost or wouldn't fall. But then, as every patient is not a patient for fixed, we kind of give them something in between. So I feel that fixed is the best option, but then comes the topic I'm going to speak about, that is implant supported overdentures. So if we have a choice, any day an overdenture, even if it's tooth supported or implant supported, is a better choice than giving conventional dentures. So conventional dentures should ideally be our last choice. Now, having said that, we need to understand what implants, the type of implants which we can use. So there are these single piece implants and the two piece implants. The single piece implants, though they are narrower and they're easy to place, and there are a lot of things, and everybody feels that, okay, it's simpler to place, and they can be placed on the dentures, and they have been placed very, very commonly in the past. But the biggest issue is that placement has to be, especially in overdentures, the placement has to be absolutely parallel, because there are no options to improvise, later. And that is why we are, at least in my practice, I have kind of shifted all the implants which we are doing are two-piece implants currently. They have varied prosthetic options, and that truly helps for us to work around any discrepancy or anything. We can make changes later or add on more implants, and probably shift a patient from partially removable, to a fixed prosthesis. So how to plan for overdentures? So now, any kind of prosthetic, any kind of work that we are doing ideally should be pre-planned. We do not want to go in blind. And that is why for overdentures especially, there are three parts to it. One is a pre-surgery plan. The second is the surgery phase. And once the implants are, stable, then we have the prosthetic phase. So earlier we used to just have X-rays and bone mapping and everything, but now with the advent of CBCT and markers, it is much simpler. So it is strongly recommended that when we are sending the patient for a CBCT imaging or even an OPG imaging, we must ensure that if the patient is already a denture wearer, then we can get a duplicate denture made, or we can just get like a stent made wherein we can put some markers which are radio opaque. GP points can be, made and filled in these vents that are created in the old denture or stent. And once the CBCT or any kind of imaging is done, we can see these radiopaque markers, and it really helps with the precise planning. All right. So apart from the CBCT and the markers, we have to clinically also understand that do we have enough space for the placement of the kind of prosthesis we are looking at? Like for overdentures, are we looking at a bar, or we're looking at just locators or attachment or any other kind of attachment? So for that, we need to have enough space that is present because we need to maintain the vertical. And also, if the bone is not, if you don't have bone is very ragged, at least we will know that initially and work around it. So it does not help to work blind at all. So once we know how much space we have, as I said, we can decide the type of prosthesis, positioning, placement, and the number of implants. Now, this is a case where we had a little bit of lack of space, and the bone was, not flat, and the implant freehand, as I was placing, I knew it would be a problem. So in such cases, you can gain the space as well as create a platform so that the implants can be placed with ease. Once we have created the space, the implants are placed and in a pre-planned position, and it's closed. So it helps to plan. Second is that, as parallelism is the key, there is, guided surgery, which is available, guided kits, which are available to us now. So though very often I have been using freehand placements, even in certain cases where I feel the parallelism is really needed, and I, I need help a little bit, because guided is literally hand holding. So if we are doing a guided surgery, we are sure that, you're going to get a in most of the cases, it's going to work out. So parallelism is the key. So, and that is where, guided surgery comes into play. Now, once we are done with the planning, the pre-surgical and surgical part of the implants placement, and now we are ready. We have already planned what kind of a prosthesis we're going to give the patient, but that's the third step, wherein we are actually do what we have planned, and that is where we have to take the impressions or scans of the implants which we have placed. So there are two ways of doing it. One is that you do a chair side pickup, or that you have made the denture, and after that we create space in it and we do a chair side pickup. And the second is that we make impressions which are and send it to the lab. Now those impressions can either be implant level, that is, we can, as you can see on this on the screen, that we take implant level impressions. It has to be taken on a custom, like a custom tray, so that we can get the borders also properly, because what we are doing here is not like a completely fixed thing. Our borders are going to, even if they are not very, very overextended, they're still going to sit in the patient's mouth. And it's important that they are not overextended, or they are not so short that the food is going in. So for all of that, we will kind of have to do a proper, impression. And for that, it really helps to have a custom tray. So these are the implant level impressions which are sent to the lab. Once they're in the lab, now the final cast the lab has, so we don't have to do any pickup in the mouth. So the second way of doing it is to have locator level impressions. That is that, or, basically the attachment is placed in the mouth in the initial sitting. When in the prosthetic phase, we place the, let's say here I've used locators. So we place the locators, and everything is put in the mouth in place. And every time, for example, if there is a jaw relation or if there is a trial, the denture base actually fits on it. So the chance of movement is not there. And at every stage, you kind of check the fit, which is missing which was missing earlier on the implant level impressions. So that is the second way of working through it. Here also, we don't have to do anything. Finally, everything would be in the denture. We don't have to do any pickup. The third way of doing it is that we fabricate the denture completely. We do all the steps which we do like a conventional denture. Once the denture is completely ready, that is when we create space within the denture and we pick it up in the patient's mouth. When we do that, we have to ensure that there's enough space for, there's vents, they're present for the material, the excess material to actually come out so that it does not, block things. So that is the third way of doing it. It is not about which way is better. It is more about, like, I prefer implant level impressions or, abutment or locator abutment level impressions. I prefer those. But then a lot of people do chair side pickups as well. I have done. And so whatever it's, whatever you're comfortable with, it can be done that way. Now, this is like a basic overview of how an overdenture is done or how it should be done. But then, we kind of tweak it according to our needs and work around it. So first, we need to also understand that, what kind of overdenture attachments are available to us. So there are lots. If you open the books or if you see what, you speak to the dealers and you kind of understand what is available, there are different kinds of things available. And, our technicians can help us with those. And but the thing is in the market, but the thing is that there are few which are most commonly used in overdentures. Like these are the ones which most commonly everyone uses until there is a situation where you need to tweak it and use something very different, right? Okay, so the most common is the ball attachment. So this is a case which I would like to share with everybody. This is an 81-year-old lady. Yeah, and the reason I've chosen cases of patients who are very old is because age is no bar. Like we don't, just because someone is a certain age does not mean that, they are not good patients for implants, because honestly, they are better patients for implants if they are medically not very compromised, because then they don't really have to, worry about things moving, and, their quality of life improves. So this is an 81-year-old lady, and she had approached us. She had remaining 5 teeth in the upper, and she had around, I think, 2 teeth in the lower. And the treatment plan which we had for her was that we'll remove all the teeth because she couldn't chew properly and her smile was compromised, and she used to feel socially very awkward with her friends. And that is when we decided to remove all these mobile teeth and place 2 implants. So for upper, we decided to go ahead with a conventional denture. And for the lower, we decided to place 2 implants on the day of the extraction, the same day, so that she doesn't have to incur more trauma on a different date. So we did a regular denture for her. Like for the upper, we did a regular impression. For the lower, we did implant level impressions. And once that was done, the lab sent us like a for a trial. We checked it in the mouth. Again, once it was all done, the lab sent us the attachments, the male and the female attachments. The ball attachments were screwed in on the implants in the patient's mouth. And the denture was ready with the female attachments with the housing as well as the silicone nylon ring. So it is placed in the mouth. Now this patient, this is a 3-year recall. And though there are stains and everything, the patient is comfortable. She can chew. There's a bit of adhesion. Her bite is not very strong, so she is really comfortable. So now she was 81 when we did her treatment, and now she's 84. And this is something which proves to us that quality of life can be improved by placing 2 or 3 implants. And we don't have to think that someone is a certain age. So, elderly we cannot work on them. All right, so this is what I wanted to showcase, the quality of life before and after. All right, so ball attachments are the simplest and the most common of the attachments that are used for overdentures. But now with time, we have kind of shifted to locator attachments. There is a difference between them, which I'll be talking about later. Before that, I want to just showcase a case. So this patient is a 69-year-old lady. And for her, again, we decided she's completely edentulous, and we decided to give her a maxillary conventional denture with a mandibular implant treated overdenture. This is her maxillary arch in the impression. Lower, again, we did implant level impressions, and we did a jig trial, and eventually 3 locators were placed because she's younger, her bite is stronger, And we do not want that, these anything should get loose, or we don't want, I know that her bite is stronger, so a little extra implant doesn't hurt. So that is what we've done here. This is her before, and I would ask her to smile and she wouldn't. So this is after, and after that she was very comfortable clicking, with me, that I could click pictures, and she was very okay, and she gave all the permissions. And I keep talking about the quality of life, so I would like to play this video. It's a small video just to show how much difference as dentists we can make into a patient's life.
कैसा लग रहा है आपको? अच्छा लग रहा है. अच्छा लग रहा है.
Right? So you can see her eyes, you can see her happiness. And this is not the day of the delivery. This is actually 2 days after, because I wanted to make sure she was fine, and she still is fine. So this, we are all doing well. So just placement of a little bit extra, a little bit effort, and the patient is so much better. All right. So now we've spoken about ball attachments and locators. So if there is a choice, preferably locators are definitely better, because they have a larger degree of divergence. So around 15 to 20 degrees, they can, move a little bit. So obviously we want the implants to be parallel, but locators are relatively easier to navigate with a little bit of, divergence or degree of variation, that is 15 to 20 degrees. Second is, in ball attachments, the biggest issue is the localized stress, because there's a thin neck of the ball attachment, wherein the stress kind of becomes a point and goes into a certain place, and from there they kind of either break or they flatten. And because the stresses are concentrated on certain areas, there's a huge chance that the nylon rings will wear faster, which we've seen in our practice that happens. And because of the quicker wear, especially in patients with maybe younger patients who are have a stronger bite, they wear much faster, causing loss of retention. So their nylon sleeves have to be changed again and again. And that is something we can, probably avoid if we shift to locators, or reduce if we shift to locator attachments. Also, the locators are shorter in height, so they are less discernible to the tongue in the oral cavity, and it's ease of wearing. So patients are more comfortable with locators. Yeah. All right. So we've spoken about ball attachments and locators. And the third most common type of attachment is a bar attachment, wherein it is, usually 2 or 3. Usually that's 3 implants, but we've used on 2 as well, because it depends on the arch form. Now, how they are placed is, one is that you have the undersurface, which is convex, and it, kind of sits very firmly on the remaining ridge, and food doesn't really go in because it's like a positive impact there. But patient is explained how to use a water flosser and to ensure it's clean. Now, so this is one type wherein the undersurface of the attachment, the bar, is positively touching the ridge, right? Okay, and the second one is that we keep a little space in between. So if there is space, then the food can easily be cleansed just by rinsing. So that is the second way of doing it. So I'm sharing a case now. This is also, this patient is really old, but she's very healthy. She's 84-year-old, and she has an upper partially edentulous arch and the lower completely edentulous arch. Very healthy. She would sit in a rickshaw and she would come on her own without any problems at all. She has no known diseases and she's physically very fit. So the only issue is that inability to tolerate prolonged periods of treatment and need someone for the transport. So she would come in an auto rickshaw with a helper, but she wouldn't be able to travel alone. And that was one thing we had to work around that. And her chief complaint was that since, like, she took for 2 years, she was, trying to get, she was edentulous and she was trying to adjust with a lower denture, which just wouldn't stay in place. And that had somehow affected her because she's socially very active, and that had affected her, and she was quite unhappy the day she actually came to us. So her first visit, you can see I asked her to smile. She doesn't look very happy. She did her best, but obviously she was uncomfortable. So the things to consider here were, apart from the CBCT and everything which we got done, we had to see clinically the interarch distance, because she still has teeth in the upper. Second, why was she not getting adjusted to any kind of denture, and she had pain and she would throw out because there was not enough alveolingual sulcus for the denture retention, but also the tissue was not keratinized, it was soft. And third was because she was manual, like she was fit, we knew she could maintain her oral hygiene, and manual dexterity was fine, so that was not a problem with us. Tissue was slightly, she would say that it was just uncomfortable. So treatment plan was bar supported overdenture on 3 implants with 4 ball attachments for retention. We removed the second molar in the overdenture to reduce the cantilever, and we ensured that the denture was not pressing any side on her tissues. And this is her upper arch. This is her lower. This is where 3 implants were placed. And tissues after the implant placement and with her maintaining the oral hygiene, everything looked okay. This is the impression which we made. It was again an implant level impression which I had made. And this, as you can see, is for the jig trial. We decided, as I mentioned, to go ahead with a bar, okay, with 4 ball attachments on top. And this is when we placed it in the mouth, it was screwed in. She has been with me now for at least 2.5 years, and she's maintaining the oral hygiene. She uses the water flosser carefully, and she has a helper who's very good. And, so this was a right call. And whenever she's chewing, the denture really doesn't impinge anymore on her tissues because most of it is sitting on the bar. And this is her before and after, and she was very comfortable. So this is again, so every patient is different, and we work accordingly and we plan accordingly. So let us, keep all our options open. This is her before and after. I always speak about quality of life, and that is something I've learned that this should not be ignored. And let us give our elders the best we can. And this is a small video because when initially I asked her to speak, she was not very happy. But on the trial, when she came in for a checkup and a follow-up, this is what I just told her to say 1, 2, 3, 4, and this is how she looked.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Smile. अभी कन्नड़ में बोलता है अच्छा बोलिए 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17 18 19 बड़ा मुंह खोलिए बंद करिए अभी लूज नहीं लग रहा.
So this video is just, it just shows, look at her eyes and look at her smile, and she's a changed person. So this is what we want to achieve. And that is, at the Board of Geriatric Dentistry, we want to give all our patients this kind of happiness and quality of life and function and aesthetics and ability to chew and, do everything they could do when they were younger. And that is why this whole presentation and this whole conference, Geriadent, we are doing to ensure to raise awareness and so that all of us as clinicians can come together and treat our elderly the best we can. So thank you so much. Implant overdenture, enhanced quality of life, knowing your limitations, but whatever the limitations are, we do not give up. Thank you so much for listening to me.